my resident colleagues here as well. So thank you for all coming here. And the reason to do this presentation or do this talk is lots of time I get asked this question: how to give midazolam or how to give rescue medication to children when they're having a seizure. And many people, believe me, there are many people around who are actually carers who don't know how to give it. So this is the purpose of this particular presentation. We already answered the question that what is seizures and what is epilepsy. So just for people who are listening for the first time, seizure is caused by an abnormal electrical discharge which comes from the brain for whatever reason, and that leads to multiple problems in the child, which includes motor problems, behavioral arrest, and sometimes even psychological issues as well. So that's a sudden electrical abnormal discharge from the brain. Now, just a brief background why we're doing this talk. So there are carers of children who have epilepsy. They need to know how to give the rescue medication. There are residents like yourselves who need to know how to give it. There are some people who have epilepsy and they want to teach it to other people that if we have seizure, how do you look after us? And just for a general population, how to deal with that. A word of caution that there are multiple types of seizures which can happen. So people think that the child is having a generalized jerking episode and that is what a seizure is, which is not completely true. That is something which you see commonly and you relate commonly as a seizure or epileptic attack. But there are different types of seizures. For example, you can have an absence attack or absence seizures. What happens in that? You just go blank. And sometimes you have facial automatism, which is lip smacking, and then you are in that sort of frozen state for a few seconds and then you're back on your what you're doing. It's a very short attack, which happens and doesn't need emergency medication. But imagine if it keeps happening multiple times a day and then ultimately the child starts to have cognitive problems. You need to stop that as well. There are focal seizures in which you just look to one side, your head turns to one side, and you may have a couple of twitches of your face, right? That's also a focal seizure which need to be addressed. If you have a prolonged focal seizure, I've had kids with type of seizures in which their eyes are fixed to one side for 5-10 minutes and the parents or the carers do not realize that there are seizures. So you've got to look at that as well. If that is a prolonged seizure, you need to stop that as well. And then there are other types, for example, the tonic in which you go stiff, and then tonic-clonic that you go stiff and then you stop to jerk. So all those seizures need to be addressed or stopped if they are prolonged. So what is a prolonged seizure? You must have heard about definitions of status epilepticus. Old times we used to say a status epilepticus is one which lasts for 30 minutes. We do not accept that nowadays. ILAE, which is International League Against Epilepsy, has come up with really nice definitions of prolonged seizures. When I started as a resident, as a junior or a neurology resident, we were told that we should not let the seizure go beyond 5 minutes. Now we are actually coming down from that as well. So we say if a child is coming to ER or emergency room fitting, you have to actually think that this child is already in status, because God knows how long they were fitting in the car or at home. So if you have a child who's actually seizing in front of you, that is prolonged status epilepticus for all practical purposes. Now that's where the rescue medication comes in. When do you give rescue medication to the child? So there are basically simple principles for that. Principle number one is if you have a prolonged seizure which you feel has gone beyond 3 minutes. So I've come down from 5 to 3 now. So most seizures which stop within 1 or 2 minutes, you don't need to do anything. But if you think a seizure has gone beyond 3 minutes, that has to be stopped by giving rescue medication, number one. Rule number two, if you have a small seizure lasting for 30 seconds and the child goes to sleep, and the child wakes up again, has a 30-second seizure, goes to sleep. If you have a third attack within 24 hours, that cycle needs to be broken. Okay? So you tell the carers that you give rescue medication if your child has a third attack or is having a third attack, even if it is a small one. Clear? Okay. Now coming to the rescue medication itself. In the whole world, we have different types of rescue medication, and each country has their own regulations, how it is used and what is given. There are different types. For example, you have buccal midazolam, which is given in the buccal area, which I'm going to show you. You have rectal diazepam, which is like a suppository, which is given up the bum of the child. And you have nasal midazolam, which is intranasal in certain countries, which is given up the nasal cavity as a spray. Where we are right now, we have rectal diazepam, and also some places we have buccal midazolam. I'm going to show you both. Buccal midazolam because I personally feel, and my colleagues around the world feel, that if you have a child who's under 4 or 5 years of age, it's easy to give rectal diazepam. But if you're more than 4 or 5 years of age, it's slightly socially unacceptable. Now imagine a boy or a girl who's 8 or 9 years old and they're having a seizure in a school and you have to kind of get their trousers off and give them rectal diazepam. If nothing is available, it's fine. It's fine to give because you have to stop the seizure. That's a priority. But you have the option. We recommend as neurologists that buccal midazolam or intranasal midazolam is a better option. Yeah. Now, what happens now? So, can we have this on the dummy, please? Just hold that. Thank you. So, imagine a child is having a. If you guys can just look at this as just step back a bit. It's okay. You can be a little bit back. You can also see that. Imagine a child is having an active seizure in front of you. As a carer, the first thing is very important is not to panic, because panic is not going to stop the seizure. If you're a doctor in front of the child, do not panic. We always say keep talking to the child, keep gently kind of stroking their arm or something, and keep talking to them, because many a times children can still hear when they're having a seizure. So reassure them. If the head is jerking a lot, you can support the head gently. Okay, support the head gently if you can, if you want to. Make sure there is nothing around the child which is going to injure the child. The worst thing which will happen is that there is something, an object, something which are hitting the child and they get physically injured. So make sure there's nothing around them to cause them injury. If you can't support their head and talk to them. Do not put your fingers or anything in the mouth to take the tongue out, or do not do that. That's a big no-no, because when the children have seizures, when the children have seizures, they can have their teeth clenched. And if you put a finger in the mouth, you can lose your own finger, they can choke on it. So please do not put anything in the child's mouth. If you have something coming out of the mouth, for example, if they were eating something and you can see it hanging outside, just from outside take it away. But do not put your fingers in the mouth. That's a key here. There's a misconception that the child will choke on their own tongue. Absolutely not. Okay, that doesn't happen. So don't worry about that. Right, coming back here. So when the child is having a seizure, lots of parents said to me that we were told the child to put on the left lateral position when the child is having a seizure. That's a myth as well. You put the child on a lateral position when they stop having a seizure. Yeah, not when the child is actually having a seizure. So if a child is shaking and rigorously having a tonic seizure or a generalized tonic, and you do that, you might cause them more harm. So let them do what they're doing where they are at that point of time. Make sure you time yourself. The carers who are listening to this talk, please time yourself. And if you feel that 2 minutes are passing over, get your rescue medication ready, because by 3 minutes, you'll have to give the rescue medication. Now, next question, how to give it? So let's have a look at that. So this is a standard bottle of I'm not going to show you what it is. It's a standard bottle of, let's say, a midazolam company, which provides buccal midazolam. The way that the cap works is there is only one particular syringe which can go into that. No other syringe can go in there. So you can't make a mistake. Okay? And then the doctor, whatever they've prescribed you, you use that amount of the medication. And it is numbered on there, how many milligram or how many ml is it. So let's say for practical purposes for this particular talk, this is a big boy who can have full dose of buccal midazolam, which can go up to 10 milligrams at time. So you get, only this thing will go in the bottle. You withdraw full 10 ml and you're ready with the full 1 ml, which is 10 milligram strength. Now, while the child is, now you know that the child is having seizure for 3 minutes, what do you do? Now, this is very important. All of you, please have a listen to this. This is buccal midazolam. So, quickly. This will get absorbed under the mucosa. This is not for the child to swallow, okay? So do not put this thing into their mouth like that. Their teeth is already clenched. You cannot put this in the mouth. Okay, so you need to look at the buccal mucosa. So basically, which is this side of your mouth, which is between the teeth and the cheek. Okay, inside your buccal mucosa, which is just in front of the teeth and behind the cheeks there. So what do? So you quickly put this in there and you give half the dose on this side. And if you want, you can gently just squeeze the lips so that it doesn't come out. And then you rub the cheek. So again at me, please. So you basically massage the cheek from there so that the medicine gets absorbed underneath. And then the half of the medicine, you go the other side and you insert it there. You want to gently hold the lips, that's fine. And you give a massage on this side as well. and then you keep doing that while you're talking to the child. And up on me again. So what will happen? Majority of cases, within 30 seconds, the medicine gets absorbed in the buccal mucosa and the seizure stops. Once the seizure stops, then you turn the child to the left lateral position, supporting their head so that they don't flop over, and you keep talking to them. Somebody else calls the ambulance in the meantime to get the child over to the hospital. Okay? And that's how you give rescue medication, buccal midazolam, in children. I don't have intranasal midazolam with me, so I can't show you that. And I'll just now give you a brief about rectal diazepam, just a quick kind of how to give rectal diazepam. So imagine this is a little baby who's having a seizure, and you've been prescribed rectal diazepam. The principles remain the same, exactly like buccal midazolam. Okay, so again, the principles are a long seizure lasting for 3 minutes or over, multiple seizures within 24 hours, even though they are short lasting and the child is not regaining consciousness in between. The principles remain the same. The same principle applies for epilepsy, febrile convulsion. It's absolute, doesn't matter whether you have a febrile convulsion, prolonged one, or a complex febrile convulsion, or epilepsy. The treatment or management for emergency remains exactly the same. So, same principles apply for a baby. So sometimes what happens is that the carers hold the baby very tight when they're having a seizure. Please tell them, you want to hold the baby, it's fine, but hold them snugly, because you're going to injure them if you hold it too tight. Or best, leave them on the bed, make sure there's nothing around them to cause any harm, because the last thing you want to do again is cause harm. How to give rectal diazepam. So there are different ways of it. This is a dummy, so we can't actually show you how to do it, but it's very simple. So if it's a small baby, you can take the pampers off, nappies off, and then you have the rectal tube. This is not how it looks like. It's looks like a paste kind of thing with a nozzle in the front. I don't have it in front of me today. So basically that nozzle, you stick up the baby's bum, and whatever dose the doctor has given, you squeeze that tube, take it out. The key here is to hold the bum cheeks together so that the medicine doesn't come out. So what happens is, a common mistake which happens, the parents say, we gave the medication, the child didn't stop having seizure. And then you ask what happened, they said the child pooed the medication out. So it's very important that you advise the parents to hold the bum cheeks together so that the medicine stays in for at least 30 seconds. Once the medicine stays in for 30 seconds, it is most likely to stop the seizures there and then within half a minute. And then you can turn the child again to the left lateral position, holding their head, call the ambulance to take the child to the ER. A very important point for people who are carers around the child. For us as neurologists, a video of the event is very important. So if you haven't taken a video of the child's having seizure, please take it, because it helps us to understand what type of seizure it is. It helps us to understand what medication to give to the child if the child is not responding to the one which we've given, and further investigations if we have to do depending on the type of the seizure this particular child is having. So in nutshell, in summary again, before that, any questions from anybody? Do you have any questions, or we can do it later on?
There is a question indeed.
There is a question. Please ask me.
Doctor, won't flexing their legs during the seizure is harmful?
So, good question. So the child is having lots of seizures and there is jerking, no need to flex. You can just keep the legs straight there. And by the way, good question. Many parents actually turn the child around to give the rectal diazepam, which is also fine. So you can bring the child back and you can just hold the bum cheeks like that. So that's a very good, valid question. If you don't want to flex the child's legs if they're fitting, you don't want to cause any trauma, absolutely correct. Just hold the bum cheeks from the bottom and close it. That's a very valid point, and I agree with that. I agree. Any questions from here?
I have a question.
Yes, please.
If the seizure does not stop within 30 seconds, can you repeat the question?
Yes, that's a good question. So this talk is basically for community people who are in their homes, care homes, nurses, carers, and so on and so forth. If you are well trained, you can give 2 doses of the diazepam, rectal, buccal, or intranasal. But in majority of the cases, I advise the families that if you're given 1, call the ambulance if the child is not stopping seizure. Because if you're not trained enough to give the 2nd dose, because these medications can sometimes cause depression in the breathing. So you don't want to take a chance. However, if the ambulance arrives, you tell them, I've got the 2nd dose here, can I give or can you give? Ambulance crew is equipped and they're prepared in case the child or the young person's breathing is dropping, they can give it. So my advice to all these parents is to give the 1st dose, not stopping, call the ambulance and let them do the 2nd dose.
it is atonic, prolonged atonic seizures. Do we still give it antidepressants?
So that's a good question. What doctor is asking here is if it's an atonic seizure, which means the child is dropping. Usually in atonic seizures, they drop and they regain consciousness within seconds. So I don't usually recommend that in atonic seizures because sometimes you can have multiple atonic seizures a day. That's something for us to, as neurologists, to look at the cause for it and use appropriate medication for that. Rectal diazepam, buccal midazolam, intranasal midazolam usually is not given in brief atonic seizures, usually not. Okay, I think we can stop this today, and whoever has been listening to this, thank you very much, and please spread the word how to do this, do it right for the help of for helping the carers, the children, and the families. Thank you very much.